Shaista Noman and his team. Now, I am opening the annual conference. I request our Secretary for Scientific Affairs, Dr. A.K. Mohammadullah, to carry on the subsequent sessions. Welcome.
Assalamu alaikum. Good morning. I request the delegates to come to the front rows. Please, dear participants, please come to the front rows. I am honored to be a part of Bangladesh Rheumatology Society. I, Dr. Abul Khair Ahmedullah, welcome you to this 16th International Conference. And I welcome you to this most prestigious event, Amin Alam Oration. We are deeply honored that the oration is going to highlight such an legendary professor, Professor Amin Alam, and Professor M.A. Jalil Choudhury will speech on this session, Challenges in Rheumatology Practice in Bangladesh. Today's chairpersons are Professor Minhaj Rahim Choudhury and Professor Mujibur Rahman. And the session will be moderated by Professor Tariq Mahmood Bhuiya. May I request Professor Minhaj Rahim Choudhury, Professor Mujibur Rahman sir, to come to the dais, and Professor Tariq Mahmood, please conduct the session. Okay.
Good morning, everyone, and it's a great honor for us to have Amin Alam sir among us in a session which is named after him. Amin Alam sir is an extremely knowledgeable and simple person, and in his illustrious career, he has created some excellent disciples who have carried the mantle of him. And a mentor cannot be more precisely defined than his disciples. And thank you very much, sir, to be here today among us. So I am requesting Professor Amin Alam sir to be on the dais, to have a seat. I would like to call Professor M.A. Jalil sir to come to the stage. He is a former President of Bangladesh Rheumatology Society. He is now working at Lab 8 Specialized Hospital. Now, before starting the main event, I am requesting Professor Minhaj Rahim Chaudhuri, President-elect of Bangladesh Rheumatology Society, to have a few words about Professor Alam sir.
Assalamu alaikum. It's a pleasure and honor that I have got the opportunity to speak about a great mentor, a wonderful teacher, Professor M.N. Alam. Professor Alam was born in 1948 in an enlightened Muslim family of Kustia. He received his early education in Jamshedpur, India, where his father had been serving as a senior medical officer. He had his subsequent school and pre-medical college education in Dhaka. He passed his MBBS exam from Dhaka Medical College Hospital and received merit scholarship all through. He went to the United Kingdom in 1968 and obtained MRCP in 1969, qualified all exams in single attempt. In 1970, he returned from UK and worked in various capacities in different institutions of the then Pakistan and subsequently in Bangladesh. I am paying my deep respect and gratitude for his contribution to the development of rheumatology in Bangladesh. He was the founder and guiding beacon for the Rheumatology Society from 1997 to 2014. His dedication and service increased the rheumatological care standard in Bangladesh and inspired all professionals enormously. Recognizing the invaluable legacy and contributions, Bangladesh Rheumatology Society has introduced the Professor M.N. Alam Oration and Gold Medal since 2022. Professor M.N. Alam has an inborn quality to assist others. I have never heard him to say no to anyone who came for any kind of academic assistance. He is a great scholar and blessed with a pleasant personality. His knowledge, skill, and competencies are an asset for all of us. Professor Alam is empathetic to his patients. He possesses a high sense of responsibility. He is very much caring and loved by his patients and caregivers. We pray to Almighty Allah for his good health and longevity. Today, I am also grateful to Professor M.A. Jalil Chaudhuri that he has agreed to be the second M.N. Alam orator to make this event successful. Thank you very much.
Thank you very much, sir. Now I like to request Professor M.D. Mujibur Rahman sir to speak a few words about Professor M.D. Jalil Chaudhuri sir.
Thank you, Mr. Moderator. Dear audience, Assalamu alaikum and very good morning. The prestigious program, the M.N. Alam Oration program, this year's honor is to Professor Muhammad Abdul Jalil Chaudhuri. He is the second orator of these sessions as it was started in 2022, as you have already known. I think Professor M.A. Jalil Chowdhury, you all know about him. He is the professor of medicine. He started his career in internal medicine and he always remained in internal medicine, but he has got a deep interest in several subspecialties. One of them is rheumatology. If I say something, then it would be very difficult on my part to say about Professor M.A. Jalil Chowdhury. He was my mentor, he was my teacher, and he was my colleague also in different situations. Professor Abdul Jalil Chowdhury, former professor of medicine and chairman Bangabandhu Sheikh Mujib Medical University. He obtained his medical graduation from Chattogram Medical College in 1978, and he also obtained his fellowship in internal medicine in 1982 when I was the second year MBBS student. You mind it. During his long charismatic career, he served Chattogram Medical College Hospital, Brahmanbaria Shodor Hospital, Rajshahi Medical College, the then IPGMR, and finally Bangabandhu Sheikh Mujib Medical University. And he has kept his footsteps in different institutions of Bangladesh. He received honorary fellowship from College of Physicians of India, College of Physicians of Pakistan, the Royal College of Edinburgh and also London, and American College of Physicians. And also he received masters from American College of Physicians. He is the life member of different societies. I am not just going to the names, I am not telling those names. He is also the member of the New York Academy of Sciences. You know, he is not only in the national era, he is also in the international era at the same time. He was one of the reviewer of the National TV Control Program of Bangladesh and fifth joint monitoring mission of NTP Bangladesh. He is the member of Ethical Review Committee of ICDRB for a long time. He is the General Secretary and subsequently President of Association of Physicians of Bangladesh. He was also the Founder Secretary and also subsequently the President of Bangladesh Society of Medicine. He became the President of Rheumatology Society and he remained the President for Rheumatology Society for 3 terms. And this year, the Rheumatology Society is giving the perfect honor to him as selecting him as the orator of this session. He was the honorary secretary of Bangladesh College of Physicians, and also he was the counselor of BCPS for several tenures. He was the chairman of Faculty of Medicine of the same institute, Bangladesh College of Physicians and Surgeons, for the 2 tenures. He is the Secretary General of National Alliance of Drowning Prevention and chairman of some national foundations in different occasions. He is at present an important member of Health Advisors Expert Panel for Health Reform in Bangladesh. He has been the author and co-author for numerous national and international journal. I think it would be more than 100. It is not the 75 that has been written here. And he also authored several books in Bengali and also textbook on OSPI and OSCE for postgraduate trainees and co-author of the community pharmacology. So there are so many things to say about Professor M.A. Jalil Chowdhury. I think it will be very difficult on this very short occasion to say about him, and it will rather shorten his the duration of oration. So Professor Abdul Jalil Chowdhury, we are honoring you by these very few words. Thank you very much. Thank you, Mr. President. And at the same time, it's a prestigious session, and we are honored that Professor M.N. Alam sir is being present in this session, as the name is in his name and he is here amongst ourselves. So thank you very much. Thank you, Professor M.N. Alam sir, to be here with us.
Thank you very much, sir. It's extremely difficult to elaborate all the accomplishment that our teachers have already obtained. Thank you very much for the brief description. Now for the main session, this is a very prestigious session, M.N. Alam oration, sir. And again, we are grateful, sir, that you are present among with us. The topic of these sessions is challenges of rheumatology practice in Bangladesh. To speak about these topics, I would like to request Professor M.A. Jalil Choudhury, sir. Please welcome Professor M.A. Jalil Choudhury, sir.
إن الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه أجمعين. Amma Bad. That means I praised Allah the Great and made dua for our Prophet Hazrat Muhammad Sallallahu Alaihi Wasallam and also his Sahbis and accompanies. Good morning to everybody who has just joined us and who will be joining very soon. Ladies and gentlemen, thank you, Professor Mujibur Rahman, for your very nice words to me. It's a great privilege for me to express that I feel very honored to deliver memorial oration for Professor M.N. Alam, especially in his presence. He is my direct teacher, he is my mentor, and so he is the teacher of many teachers like me. Being an internist, he paved the way to develop various subspecialties in this country, and one of them is rheumatology service in this country. It's a proud privilege for me to share the challenges of rheumatology services, the service which that means the service which Professor Alam initiated. So let me start with the birth of rheumatology care in Bangladesh. I took charge of President of Rheumatology from Professor M.N. Alam. So I think Rheumatology Society has rightly chosen me as a second orator of Professor M.N. Alam memorial oration. So thank you so much, the office bearers of Bangladesh Rheumatology Society, for selecting me. So I am talking regarding I have started with the birth of rheumatology service in Bangladesh. So it was the womb. The rheumatology clinic is a womb in December 1992. When it was established, so far I can remember, I was at that time a student. I enrolled myself as a MD in rheumatology, MD in medicine at that time. So I was very much associated with the development of rheumatology clinic when it was in the womb. And Professor M.N. Alam was parenting the subject at that time. And ultimately, the thing was carried on by Professor Syed Atiqul Haq who now is the president of BRS, and he is a renowned international rheumatologist, and he was the president of APLAR. During that time, it was a very small clinic. It was established in, so far I can remember, in the physical medicine OPD. It was a small room with few chairs, and it was then it was accompanied by internal medicine, because at that time there was no rheumatology service, and it was attended by physical medicine people and orthopedician. And I can remember Professor M.K. Kaim Choudhury, who is now the DG of BARDEM. He was an active participant at that time. Following that, rheumatology service started to develop, and it was in the hand of Professor Syed Atikul Haq when he became fellow, WHO fellow in 1997, and it was also because of encouragement by Professor Ahmed Alam, so far I understand. And following that, after coming from abroad, Professor Syed Atikul Haq and Professor Alam take the initiative to formulate Bangladesh Rheumatology Society, and following that, rheumatology wing was developed in Bangabandhu Sheikh Mujib Medical University in 1999. When I was the professor of medicine at that time, I had some contribution to the development of rheumatology wing at that time. And MD course was started in BSMU in 2012. And so far I can understand the first MD was Professor Roshandara, is it so? And Professor Shahin, is it so? They were the first MD, though they are the actually basically they are fellow of medicine basically. And Department of Rheumatology were established in 2009 in Bangabandhu Sheikh Mujib Medical University, and fellowship in rheumatology, FCPS in rheumatology was started in I think 2005, and first fellow was Professor Dr. Rabbani. Now he is working in I think Rangpur Medical College. And fellowship in rheumatology in BCPS was started in 2005. Sorry, this is wrong. What are the rheumatology caregivers? There is varieties of groups and peoples who take care of rheumatology patients. First group is postgraduate degree holders. That is either FCPS rheumatology or MD in rheumatology. They are the pure, I think, rheumatologist postgraduate degrees, and internist or special training in rheumatology, or some internist with special interest in rheumatology, and overall internists are all practice rheumatology, no doubt. Some orthopedician also practice rheumatology, physical medicine people also practice rheumatology, neurologists also practice rheumatology. There are some pain specialists who also practice rheumatology, or the patient used to go to them for cure of pain. Some homeopathy and also the traditional healers also take care of rheumatology patients in Bangladesh. But who is a rheumatologist? There is no different criteria for the definition of rheumatologist. This is the problem. So, but there are so many medicine and bath in this country without any definition. Most probably that they are self-declared medicine and bath bishego. That means they are the pain specialist. Rheumatic disease encompasses a wide range of conditions that primarily affect the joints, muscles, connective tissue, leading to pain, disability, and decreased quality of life. So, the subject is vast, no doubt. And most of the rheumatic disease can be grouped under mostly 10 categories. systemic antidisease disease, vasculitis, seronegative SPA, arthritis associated with infectious agents, rheumatic disorders, bone and cartilage disorders, hereditary disorders, non-articular and regional musculoskeletal disorders, neoplastic disorders, and miscellaneous rheumatic disorders. In the last decades, the treatment of rheumatic disease has been revolutionized by a deeper understanding of their pathophysiology and the introduction of several new treatments with different targets and the comprehension of the importance of strategic approach to this disease. Despite advances in the understanding and treatment, managing this condition poses significant challenges for healthcare providers and the patients alike. But the challenges can vary. What are challenges today? After a few years, that this may not be the challenges, and the challenges also vary from country to country, from various ethnic groups. But the challenges, though I am talking regarding challenges of rheumatology care service in Bangladesh, but I think this is almost similar, at least in our South Asian countries. So let me talk with the first challenge. I think the early diagnosis, which is most important today, early diagnosis and early intervention is the most important challenges to deliver rheumatology services, because early diagnosis is crucial to avoid long-term complications. When appropriate treatment started early, expenditure and disability can be reduced. And so early diagnosis remains a great challenge for developing countries like ours because of lack of various diagnostic facilities. And if at all these facilities are present, there is lack of proper interpretations, and there is lack of special expertise to interpret these technological reports. Second challenge, I think, treatment adherence and patient's compliance is very much important to deliver rheumatology care in our setting, because this is the challenges for our patients with rheumatic disease often require multifactorial treatment plans, including medications, physical therapy, and lifestyle changes. The complexity of these regimens can lead to non-adherence. Many patients struggle to maintain consistent medication schedules, especially when experiencing side effects and when their symptoms fluctuate. So this is a great challenge for us to deliver proper rheumatological care to our patients. And third challenge, what I believe, is the patient's empowerment, especially country like ours. Many patients do not fully understand their condition or the importance of treatment adherence. Patients' empowerment is crucial for improving self-efficacy, adherence of treatment, and overall quality of life. Effective communication between healthcare providers and patients is essential to empower patients to take an active role on their management. And this is a great challenge because lack of manpower, lack of healthcare worker, we cannot make the patients empowered in this respect. But there are few attempts has been done to empower the patients, but these are not sufficient. Sometimes our few teachers gave lectures, but it is not sufficient for patients' empowerment in education. So next challenge is the high prevalence of comorbid conditions. Every country, every aged person has got some comorbid condition, and this poses a challenge to manage rheumatology patients. And like cardiovascular disease, diabetes, kidney disease, even peptic ulcer disease, if you give NSAID, the patient develops dyspepsia. So this is a problem for us. Managing multiple conditions can complicate treatment strategies, and as medications for one disease may exacerbate the others. So this is a challenge for us to deliver rheumatology care. At the same time, risk of polypharmacy. Polypharmacy, because of either comorbidities or because of disease condition, we have to prescribe, or many physicians prescribe so many drugs that this creates problem in managing the patients. Patients with rheumatic disease are often prescribed multiple medications, increasing the risk of drug interaction and at the same time adverse side effects. Balancing the benefit and risk of polypharmacy is a significant challenge for health worker providers. Next, inefficiency of the curriculum. Inefficiency of the curriculum. The representation of the rheumatology is poor in the undergraduate curriculum. The book is all right. Sufficient has been written in the textbook of medicine, either Davidson or any other books, but in the curriculum, these are not sufficient. If at all in the curriculum, these are not implemented properly. A similar deficiency also exists in postgraduate internal medicine curriculum. At all, if there is at all any thing in the curriculum, the implementation is not appropriate. And so, curriculum implementation is poor. Also, the training monitoring is not adequate in terms of rheumatology care. You see, I mentioned that some other groups, other than medicine group, also practice rheumatology. And there are so many Bad Visheshagya and pain specialists practicing rheumatology. Do you have inquired how much content is in their curriculum? I was talking with some professor sitting beside me. He was a professor of orthopedics. At the same time, he was a professor of physical medicine. I talked to him what amount of rheumatology taught in their curriculum. He said that 0. So with that 0 curriculum or something curriculum, practicing rheumatology. So there is inefficient topic content in the curriculum. So we have to think, are we really producing dysfunctional rheumatologists in this country? And so next, knowledge gap and knowledge practice gap. You see, there is a study, it was done in 2016 from, I think, from India. There was delay in diagnosis. Delay in diagnosis was average 18 months, plus minus 23. And ever received CHD-MRD only in 66%. And it was shown that the prescribed dose of MTX, it was started from 2.5 or to 25. So lowest dose was 2.5. And patients received MTX more than 20 milligram only in 7.8%. And subcutaneous MTX was received by only 2.2%. So there is a gap between practice and knowledge. This is only one statistics. So in our country, some Kamruz Jawan and along with other rheumatologists, they done a survey to see the knowledge level of rheumatoid arthritis patients about the disease in the developed country. They showed that disease-related knowledge of Bangladesh RA patients was poor in all domains. Improved education and knowledge will result in better disease. Not only that knowledge deficient in our context, the knowledge also deficient in rheumatology patients also. They know very very minimum regarding their disease. So infection. Infection is a major challenge for us, for rheumatologists, to treat rheumatological diseases. Developing countries like ours are prone to many infectious diseases. Most of them as tuberculosis, pneumonia, and B virus, C virus infection, and HIV is not uncommon. The risk is also is highest with TNF blockers, but high with other options as well. And reactivation of latent TB is a concern. So you see that countries with high incidence of TB, in our country it is Bangladesh 221 per lakh population, per 100,000 populations, and this is more than many countries. You see Ethiopia, there is also 119 only. In Sri Lanka, this is 63. So in comparison to other neighboring countries, the incidence of tuberculosis is higher in our country. So TB is not a problem. The problem is mainly for latent tuberculosis. You see, estimated latent tuberculosis burden in Bangladesh. Globally, this is 23%. In Bangladesh, it is 27% of the population has been suffering from latent TB. And among the health workers, this prevalence is almost 47%. In Bangladesh, it is 52%. And worldwide, it is 47%. So latent TB infection is a major challenge for treating rheumatological patients. You know, if we give any immunosuppressive conditions or in immunosuppressive disease, latent TB may flare up. So patients initiating therapy with TNF alpha blocker is a major risk factor for the development of active TB from latent TB. So this is a challenge for us. TNF inhibitors agents are also associated with an increased risk of non-tuberculous mycobacterial infection. But the problem is that these infections, which are most commonly caused by Mycobacterium ABM, are difficult to diagnose, and no screening test for them are as yet available. So this is a great challenge for us to treat rheumatological conditions by rheumatics. And this meta-analysis done in 2013 showed that the infection rate of infection with some biologists, you see, most of the biologists causes is a risk for higher infection, and least risk is with, I think, rituximab. So this is a great challenge for us to treat rheumatoid condition with biologists because of development of chance of infection. Glucocorticoids is randomly used, particularly I am talking regarding my country, it is randomly used, self-medicated, self-medication, so it increases the risk of infection. This is a study shows that this is of course in pregnant women. So higher the dose of corticoids, the chance of infection increases. So this is a great concern for us. Our socio-economic condition is a challenge for us to give proper rheumatologic care in our country. So if we look at the GDP, this is in 2016, you see our GDP is Bangladesh, this is 411, but it is raised to 2,646 in the last year, but it is much less than other developing countries. But it is, of course, it is higher than, I think, India. It is higher than, almost near to India, but it is higher than Pakistan. So this GDP is less in comparison to developing countries. Current health expenditure, this is very low in our country. So with this low health expenditure from government service, it is not possible to give proper health care in all sectors. So what is about rheumatology services? So I think you see in Bangladesh, only 2.36% of GDP is utilized for healthcare services. In comparison to, you see, even in Afghanistan, this is more than 21%. In Sri Lanka, this is 4.07%. So the lowest, I think, in this area. So the high cost of medication, particularly biologics and newer therapies, can be prohibited for many patients. There is no insurance coverage in our country, and universal health coverage has not been yet started. It is in the pilot stage. So patients may face difficulties in prioritizing their health needs. And at the same time, the cost of biologics, which is the most important treatment agents for rheumatological care, it is very much high. in Bangladesh, say for golimumab, it is US dollar 545, and cheapest one, adalimumab, it is $265 US dollar. So this is price is on a high, and rising expenditure of out-of-pocket health expenditure in Bangladesh is very high. It is almost 63% almost. I think so. In these communities, households often sell their possession to cover the healthcare cost, particularly when chronic disease requires long-term treatment. It is out-of-pocket expenditure as a percent of current health expenditure. You see, in Bangladesh, it is 66%. Because that means people had to expense at least 66% of their health cost from their pocket. So people like them, how it is possible to take remote service from us with this poor health coverage? Nearly 62% of the healthcare expenditure is buying drugs and medical consultation. So the high proportion of expenditure on drugs reflects a high level of self-treatment. They cannot go to physicians, even they cannot go to specialists. So they go for self-treatment and self-medication and traditional healers. So treatment is jeopardized. And access to healthcare and resources is a great challenge for us. But this access can vary from region to region. Patients in rural or undeserved areas may have limited access to necessary care, leading to delay in diagnosis and treatment. Telemedicine has emerged as a potential solution, but it is not universally available. Health manpower shortage. It is a matter of sorrow that Bangladesh is at the second position from the bottom among the South Asian countries in the current doctor-patient ratio. According to WHO, there are only 5.26 doctors for the 10,000 population in Bangladesh. Canada has 2.7 physicians per 1,000 population, including residents, of course. So this is a number of this slide shows number of doctors per 1,000 population. In Bangladesh, you see this is very much low, even in comparison to Maldives and Pakistan. ভারতের চিকিৎসক জনসংখ্যার অনুপাত almost 1.854. This is almost coincides with the WHO standard. Rheumatologist means MD rheumatology. I mean, for it is my self-definition. MD rheumatology in our country till last year it is 77 for 17 or 18 crore people in Bangladesh. Though rheumatology services are given by others also, but rheumatology is 77. It was started from, but it is the hope that it is increasing day by day. It is increasing day by day. And FCS rheumatology is 4, but there are some APLAR fellows or fellows from other organization, WHO fellows, and they take, I think Professor Mujibur Rahman is one of them. He took training from in rheumatology from outside, and they are number almost, so far I know, 15. And there is a hope that it is the students are getting interest in rheumatology. In this year, in FCPS, 16 candidates have enrolled their name in FCPS rheumatology after passing midterm examination. So far I understand. So this is the hope that this it is increasing. We cannot avoid the psychological factors. Chronic pain and disability associated with rheumatic disease can lead to significant psychological stress, including anxiety and depression. Addressing these mental health aspects is crucial for comprehensive management, but often receives inadequate attention in clinical practice. So this is a challenge for us to take care of their psychological aspect. Social support system is a challenge for us. The lack of robust social support can exacerbate the challenges faced by the patients. Families and caregivers may not always understand the complexities of the rheumatic disease, leading to feeling of isolation and frustration. Evolving treatment landscape. The landscape of rheumatic disease management is rapidly evolving, and the development of newer therapies, including biologics and targeted synthetic DMRDs. While these innovations offer new hope, they also require ongoing education for both providers and patients to optimize their use. And next challenge is clinical guidelines and variability in practice. You see, there are so many guidelines for rheumatic disease, but these are from outside. In our country, there are very few guidelines. Nowadays, they have prepared one guideline for rheumatoid arthritis. I think this will increase, no doubt. We should have our own guideline. This is a challenge for us because there is ethnical variation in rheumatology presentation. There is variation, maybe variation in management. We have to customize patient management in our context. So we should have our rheumatology guidelines. And difference in training and experience and interpretation of guidelines can lead to inconsistency in the treatment approaches affecting the patient's outcome. So lack of evidence-based practice. Because of absence of this evidence-based practice, there are numerous, I have already mentioned, medicine in Bata Bishego, they have self-declared Bishego. People go to them and sometimes they become cheated, no doubt. This is a few examples of prescription. You see, this is a sleep pad, and already he has prescribed Topacity extra for 1 month, 1 month. This is the example of misuse of these drugs. This is another prescription. This is by a specialist, big specialist, diagnosis MCDD, something MCDD, current disease, and so many diagnoses. Also, Topacity, obviously, of course, solve. Continue. And this is another. He is not a specialist. He is not a specialist about having so many degrees, and he has also prescribed Topacity for 1 month. For 1 month, people are happy that he will take 1 month Topacity and he will be cured. So this is another. I think this is from some specialist. He has also returned so many drugs. One of them is prednisolone, one is baricitinib, again Fevoxit. Maybe that he is suffering from multiple diseases. And diagnosis, you see, diagnosis is juvenile idiopathic arthritis of right hip, left knee, left ankle, তারপর lumbar spine, swan sore idiopathy, UTI, and he has prescribed. And there will be so many examples in the hands of our physicians and rheumatologists with this prescription, and these are few examples of drug abuse and misuse, and this is already because of lack of evidence-based practice. Research and development change. There is need for much research for most cost-effective treatment, and we need some safe drugs because anti-emetic drugs are not safe at all. They are most toxic drug, but we need our own data because treatment, there is treatment availability in different communities. We are not lagging behind in research, but these are not enough. The first cohort study was done in 2005, and there are so many people are involved, and one of them was John Darwan was, he was at that time accompanying us. I also present during this study, and you see here Professor Amin Alam. Can you recognize Professor Amin Alam? He was so young at that time. He was seeing patients in a remote area. I think this was in Munshingos or something else. and this was, I think, me, and this was Dharman. Sir, apni chintechen apnake. And you see, Professor Dharman was riding boat while he was going to this remote area to attend the court study. And the study showed that in our country, the current prevalence of rheumatic disorders are about 26%. The next challenge is discrimination between urban and rural areas. You see, most of our rheumatologists I mentioned are around the Dhaka city, capital city. There are few rheumatologists in the periphery. So there is discrepancy. Most of the rheumatology services are Dhaka based. So vast majority of people in our country are away from proper rheumatology services. But let us hope that it will improve. So internalization, yes, the rheumatology society has gone up to the international level, but they are not have gone to national level in the periphery. So this have to be reversed. Increasing aging population is a challenge for us because as the age advances, there are rheumatological conditions also aggravates, and there are so many comorbidities. Life expectancy is increasing. This is hope at the same time. This is also creating problem because aging people suffer from many comorbid conditions, including rheumatology conditions. I think I have come to the end, Mr. Chairman. Preserving core values, morals, ethics, and principles. And these are not less important, because writing a prescription, writing some drugs is the very easy thing to do. But to manage a patient, to make the patient happy is most important and most difficult job, which are ignored in many settings. And at the same time, I should mention that this has not been also included properly in our curriculum, and if at all included, these are not properly implemented. So this is a great challenge for us for managing rheumatological diseases. So you see, NSS, core values, they have mentioned, I think, for 6 to 7 core values, working together for patients. Professor M.N. Alam is an example of working together for patients, because when he started rheumatology clinic in 2009, he developed that rheumatology clinic with involvement of physical medicine, orthopedician, and medicine. So he is an example of working together for the patients. And respect and dignity, it is important, and commitment to qualitative care. Of course, we are all committed, but we cannot apply. Compassionate, also important, improving lives, and everyone counts. These are also, you know all, but these are not practiced in our country. This is not your fault. These are not in the curriculum, or in the curriculum, these are not implemented. But this is a challenge for us to deliver proper rheumatology care in our setting. You see, when you live in a small house, there is less challenge. But when you hire a big house, the challenge will increase. Rheumatology service, when it was a small clinic, there is no challenge. When it is developing, there is more challenge. And in near future, you will face more challenges, but you have to overcome it. Mr. Chairman, I like to conclude here by saying that addressing these challenges collaboratively, the healthcare community can improve outcomes and quality of life for individuals living with rheumatic diseases. Few days back, I and Professor Sayyid Atiqullah went to Professor M.N. Alam's house. We knew that he was sick, but we invited him. He did not commit, and we did not pursue further because of his illness. He talked to us. He said that he will try, and today he is with us. And I think many things can be learned from activities. Whenever he faces any challenges, we can remember him, we can discuss with him, and you can get a solution. During visit to his house, without his permission, now I am taking the permission retrospectively, I have seen a photograph given by somebody. They are written that, হাজার বছর ধরে বেঁচে থাকবে তুমি আমাদের মাঝে. I coined with this saying, he should live long among us, to mentoring us, to suggest us, to help us, so that rheumatology care services develop properly, efficiently in our country. Thank you all. Mr. Chairman, Professor Amin Alam sir, dear participants, Barakallahu Fikum. Thank you all.
Thank you very much, sir, for your elaborate presentation about the challenges of practice in rheumatology in Bangladesh. It has been rightly mentioned that delayed in diagnosis, polypharmacy, undertreatment, complications of the treatment, lack of awareness of the patient, lack of competency from the healthcare system, socio-economic conditions, psychological, psychosocial pressure, all those factors are contributed to the challenges in the treatment of rheumatological patient. And frankly, there are some studies already have taken place in Bangladesh about the what are the problem to treat rheumatological diseases, and hopefully in future we will get the real life data regarding these issues and we can properly address that. Another thing, why so many specialties are involved in the treatment of rheumatological patient. We might call it a problem, and the other hand we might also consider it as the beauty of rheumatology, because the rheumatological diseases can present with involvement of the any organ in the body. We can say it from head to toe, or we can say it from hair to toe, because alopecia is also a presenting complaints of rheumatological conditions. So as the presentation is so versatile and so many organ system can involve, so many specialties came into treatment of this condition. Now it is our great pleasure that M.N. Alam sir has consented to say some words to us for our future guidance. So please everyone, please applause Professor M.N. Alam sir. Please welcome Professor M.N. Alam sir, and we will
Thank you, Professor Jalil, Professor Minhaj, and Professor Mujib for the kind words you have spoke about me. But I think I will be failing in my duties if I do not mention several points here. One is, you have seen from the papers that rheumatology clinic was founded in 1997, April 1997. But in fact, it was founded long ago, and in the unofficial capacity, and that was 1997 was the official capacity came here. So during this unofficial period, I had to continue as president of the society, and without any help from many places. At that time, I was helped by physical medicine people, and where broken benches were there for sitting patients to sit, and the chairs were few, tools were there for patients to sit. What I want to say that in fact it all started long ago, because when back in mid 80s, mid 90s, I think, yes, I was asked to go to Japan by Novartis Bangladesh to attend a conference there. But I denied. I said that I will not go. Then they asked me, who else can replace you? I said, I gave the name of Professor Syed Atikul Haq. And when he came back, and they said that you have given the correct name. So, and after that, Professor Atik went to Singapore for training. When he came back, it was Professor Hyok Hee, I think, the lady professor, and Professor Pispati, the then president of the APLAR, who asked Professor Atik to continue with the rheumatologic problem in this country. And Professor Atik continued, and in fact, Professor Tahir was at that time the joint director of the IPGMR, which subsequently became the Bangabandhu Medical University. And Professor Atik at that time, in fact, whatever I did, it was all due to Professor Atik's effort. And Professor Atik asked me to open a clinic, open a not only clinic, then when established Rheumatology Society of Bangladesh, and it was done. And asked to I would ask to sit in his room to and to help in the development of the earliest rheumatologic society and the rheumatology clinic. Since then, Professor Pispati and Professor Hyok Hee came here. He visited us, and we were inspired by his talk, and we continued to work with the rheumatologic problem in Bangladesh. And I think I should mention here, back in 1999, when considering the enormous patient population of with rheumatologic problems, Professor Kadri did the vice of BSMU. He declared as formation of rheumatology wing there, and Professor Nazrul at that time took the charge of the and in 1990, I think, Professor Kadri Professor Kadri at that time Professor Hasnat now in the endocrine department of Professor Farid, they all helped me with in this regard. So I think whatever you spoke, it was all due to Professor Atik, and Professor Atik at that time, I had to continue as president of the society on his request, and for several years, more than 10 to 14 years, I think. And by that time, in 1997, the society was officially recognized, and so I think the great job was done by Professor Kadri, the then VC of BSMU, who declared as a wing and ultimately gave an appointment of assistant professor, with assistant professor Professor Nazrul took that professorship and continued to work. And Dr. Hasnat was with us to help me, and I think these all should be known to you, because the earlier part of this rheumatology clinic was initiated by Professor Atik and Professor Nazrul and others, because at that time Professor Kadri is no more with us. He is dead now, and but the job he did was a great job, and with initiated the formation of rheumatology service in Bangladesh. Thank you, Professor Atik.
Thank you, sir. Sir has mentioned so many things behind the development of rheumatology services in Bangladesh. Thank you, sir. Thank you, be with us in this auspicious occasion. Now, moderator, please go ahead with the next. Sir, আমরা একটু মাঝখানে যাব মনে হয়. Crest and the gold medal.
Now this is the session to hand over the M.N. Alom Oration Gold Medal to Professor M.N. Jalil Choudhury sir by Professor M.N. Alom sir himself.
Learned audience and ladies and gentlemen, this is the
Now a small memento is presented to Professor M. A. Jalil Chaudhuri sir by Professor Syed Atekul Haq, the President of Bangladesh Rheumatology Society.
Ladies and gentlemen, let's take a break for tea. Please enjoy the refreshment. Thank you very much.
All ladies and gentlemen, all the faculties, teachers, especially for professor and foreign faculties, please attend our tea break at Hall Ruby Hall, and all others are requested to take snacks in front of this ballroom. And the total time is only 15 minutes for tea break. All the faculties, professor and foreign faculties, please go to the Hall Ruby for your snacks. Thank you.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.